Welcome to Nightshift Horror. Before we check in tonight, don't forget to like, subscribe, and let me know where you're tuning in from. Now get comfortable. The night shift is about to begin.
I found the door at 2:47 in the morning during my third medication round. It shouldn't have existed. The corridor ended at Ward 12. I'd walked it hundreds of times. But that night, past the supply closet and the staff bathroom, there was another hallway, dimly lit, the same industrial gray as every other wing. And at the end, a locked steel door with a small reinforced window. The placard read, Ward 13 in the same regulation font as all the others. I stood there with my medication cart staring at a space that hadn't existed during my orientation 6 months earlier. My badge wouldn't unlock it. I tried 3 times. The red light blinked and the door stayed shut. When I returned to the nurse's station to check the duty log, Ward 13 was listed on the updated floor map. It had always been there. I started working at Pine Haven State Psychiatric Hospital in June of 2014. The facility sits deep in the Green Mountains of Vermont, about 40 minutes outside Rutland, accessible only by a winding 2-lane road that becomes nearly impassable in winter. Pine Haven was built in the 1930s as a tuberculosis sanatorium and converted to psychiatric use in the 60s. The architecture reflects that history, long, narrow wings radiating from a central administrative hub, high ceilings and windows that don't open. By the time I arrived, the hospital housed roughly 80 long-term patients across 4 active wards. Most had been there for years, some for decades. I was hired as a psychiatric registered nurse for the overnight shift, 11 p.m. to 7 a.m. The work was exactly what I expected: medication administration, safety checks, documentation, and crisis intervention when necessary. The patient population was stable: chronic schizophrenia, treatment-resistant mood disorders, a few forensic cases transferred from corrections. Nothing I hadn't encountered during my training in Boston. The night shift was quiet, lonely sometimes, but predictable. I liked the routine, rounds every hour, charting every 2. The rhythm of it felt solid. Pine Haven operated on a strict protocol system. Every action required documentation. Every door required proper access credentials. Every patient interaction followed a standardized format. During my orientation, the nurse educator walked me through each ward. Ward 10 housed women with severe mood disorders. Ward 11 was geriatric psychiatric care. Ward 12 held male patients with psychotic disorders. That was it. 3 active wards on the north wing. The south wing had been closed since 2008 due to budget cuts. I was told never to go there. The doors were chained. The night I found Ward 13, I was working alone. That wasn't unusual. Overnight staffing was minimal. 1 nurse per wing, 1 supervisor for the entire facility, and a single security guard who spent most of his shift in the parking lot. I'd completed my 10 p.m. rounds without incident. Medications delivered, patients asleep or quietly awake in their rooms. I was pushing my cart back toward the nurse's station when I noticed the corridor. At first I thought I'd taken a wrong turn, but I knew the layout. I walked this route 4 times a night, 5 nights a week. There was no hallway past the supply closet, yet there it was. I stood at the threshold for a long time, listening. No sound came from beyond the door at the end, no voices, no movement, just the low hum of the HVAC system. I approached slowly. The door was identical to all the others: steel, small window, magnetic lock. I held my badge to the reader. Red light. Access denied. I returned to the nurse's station and pulled up the facility map on the computer. Ward 13 was clearly marked on the north wing schematic. The layout showed a corridor and 6 patient rooms. I opened the staffing schedule. No assignments for Ward 13. I checked the patient census. No names listed. I scrolled through the medication administration records. Nothing. I sat there staring at the screen, trying to reconcile what I was seeing. A ward that existed on the map but not in the staffing or patient systems. I called the night supervisor. Her name was Diane. She'd worked at Pine Haven for 18 years. When I explained what I'd found, there was a long silence on the other end of the line. "Ward 13 isn't part of your assignment," she said finally. "I know," I told her, "but it's on the map, and the door is here. I don't remember seeing it before." Another pause. "It's a restricted unit. You don't have clearance." "Restricted for what?" "I can't discuss that over the phone. Just continue your regular rounds." She hung up. I finished my shift without incident. I documented my rounds, completed my charting, and handed off to the morning nurse at 7 a.m. I didn't mention Ward 13. I wasn't sure what I'd say. The next night I arrived early and checked the map again. Ward 13 was still there. I went to the north wing and walked to the end of the corridor. The door was exactly where it had been. I tried my badge again. Red light. I leaned close to the window and peered through the reinforced glass. The corridor beyond was dark. I could make out the shape of another door about 20 feet down. Nothing else. I started asking questions, carefully. I approached one of the day shift nurses during handoff and mentioned I'd noticed a ward I didn't have access to. She looked at me strangely. "Ward 13 has always been there," she said. "It's just not active." "What was it used for?" She shrugged. "Before my time. I think it's storage now." But it wasn't storage. Storage units don't have patient rooms on the facility map. I checked the employee manual. There was a section on restricted areas. It listed the south wing, the basement mechanical rooms, and the old hydrotherapy suite. No mention of Ward 13. I searched the digital archives for policy updates. Nothing. I asked the night security guard if he ever patrolled that corridor. He said he'd never been down there. He didn't have clearance either. 2 weeks passed. I continued my rounds as assigned. Every night I walked past that corridor. The door was always locked, the hallway always dark. I started paying closer attention to the documentation, patient logs, incident reports, staffing records. I was looking for gaps, inconsistencies, anything that might explain why a fully mapped ward existed with no official acknowledgement. I found the first discrepancy in a handover note from 3 years earlier. A previous night nurse had written, "Patient transferred to Ward 13 per Dr. Gallagher's order. Condition stable." The note had no follow-up. I searched for the patient's name in the current census. Not listed. I checked the discharge records. Nothing. I looked for Dr. Gallagher in the staff directory. The name appeared in archived schedules from 2010 to 2012. After that, no record of employment. I found 6 more notes over the next month, all brief, all referencing Ward 13, all involving patients who no longer appeared in any system. Transfers, condition updates, medication changes, but no documentation trail beyond the initial note. It was as if the patients vanished the moment they entered that corridor. I started keeping my own log. I recorded every reference to Ward 13 I could find, dates, patient names, staff members. I noted changes in the digital floor maps. Small things. The corridor appeared on the night shift map, but not always on the day shift version. Room numbers within Ward 13 occasionally shifted. Once, the placard on the door read, Ward 13A. The next night, just Ward 13. I brought my findings to Diane during a scheduled supervision meeting. I laid out the notes, the inconsistencies, the missing patients. She listened without interrupting. When I finished, she closed the folder I'd prepared. "You're documenting something that isn't part of your job," she said quietly. "I'm documenting a discrepancy in patient care." "There is no discrepancy. Ward 13 is a long-term stabilization unit. Patients transferred there are under specialized care. You don't have clearance to access their records." "Then why isn't it listed in the staffing assignments? Why aren't there medication orders? Why can't I find discharge summaries?" She stood up. "Because it's not your assignment. And continuing to ask questions about it will be noted in your file as a boundary violation." I stopped asking questions out loud, but I didn't stop looking. In December, I found a file box in the medical records room. It was mislabeled, Ward 10 Archives, 2007. Inside were intake forms for Ward 13, 23 patients, all admitted between 2008 and 2011, all described as long-term stabilization candidates, all signed by Dr. Gallagher. I photographed every page with my phone. That night, I tried my badge on the Ward 13 door again. Green light. The lock disengaged. I stood there for a long moment, hand on the door. Every part of my training told me to walk away, to report the access error, to follow protocol. But I didn't. I pushed the door open and stepped inside. The corridor was identical to every other ward. Same tile floor, same fluorescent lights. 6 doors, 3 on each side. Each door had a small window and a patient name placard. I approached the first door and looked through the glass. The room was empty, bed made, no personal belongings. I checked the placard. The name matched one from the file box. I moved to the next door. Also empty, same configuration. I checked all 6 rooms, all empty, all identical, all labeled, identical, with names from the archived intake forms. I walked back to the nurse's station and pulled up the facility map. Ward 13 still showed 6 patient rooms. I checked the live bed census. No patients listed. I checked the medication administration records. Nothing. I went back to the corridor and took photographs. The empty rooms, the nameplates, the sterile waiting quality of the space. When I left that morning, I uploaded the photos to a personal cloud account. 2 nights later, my badge stopped working on the Ward 13 door. Red light, access denied. I tried multiple times, nothing. I checked the map. Ward 13 was gone. The corridor still existed, but the door at the end now read Storage Unit 7. I walked down and looked through the window. Shelves, medical supplies, no patient rooms. I checked my phone. The photographs were gone, not deleted. Simply absent from my camera roll and cloud account. I checked the file box in medical records. Empty. The intake forms I'd photographed had vanished. I requested a meeting with the hospital administrator. I explained everything I'd found, the discrepancies, the archived notes, the missing patients. The administrator listened carefully. When I finished, he opened my employee file. "You started here in June of 2014, he said. "Yes. According to your onboarding paperwork, you signed an acknowledgement of restricted areas during orientation." He turned the file toward me. My signature was at the bottom of a form I didn't remember seeing. The form listed Ward 13 as a specialized long-term stabilization unit with restricted access. The date was June 9th, 2014. "I don't remember signing this," I said. "It's your signature." "I know, but I don't remember the conversation." He closed the file. Ward 13 serves a specific patient population under a separate administrative structure. You were informed during orientation that inquiries about restricted units constitute a boundary violation. This is your formal warning. Further documentation of this nature will result in termination. I left the meeting in a fog. I went home and searched my email for any reference to the orientation. I found the welcome packet, the schedule, the checklist of completed trainings. No mention of Ward 13, I kept working. I stopped asking questions. I stopped looking for discrepancies. I completed my rounds, documented my patients, and went home. But I couldn't stop thinking about those 6 empty rooms, the patients whose names appeared on doors but nowhere else, the intake forms that existed and then didn't. 3 months later, I received an updated floor map during a mandatory safety training. Ward 13 was back, listed clearly on the North Wing schematic. 6 patient rooms, no staffing assignments. I didn't say anything. Last week I was asked to cover an extra shift, double overnight, 11 p.m. to 11 a.m. During my 4 a.m. rounds, I walked past the corridor. The door to Ward 13 was propped open. I could see the hallway beyond, lights on. I heard voices, quiet conversation. I stopped and listened. 2 people talking. I couldn't make out the words. I looked down at my assignment sheet. My name was listed under Ward 13. Overnight rounds, medication pass, documentation, my handwriting, my signature. I don't remember signing it. I still work the overnight shift at Pine Haven. I complete my rounds. I document my patients. I follow protocol. But now I understand. Some assignments aren't given, they're discovered. And once you find them, the paperwork catches up. They always knew I'd open that door. They were just waiting for me to realize I already had. Story 2. The radiology queue. I pulled up patient 7341's file for the 6th time that week and stared at the scheduling timestamp. September 24th, 2020, 8:14 p.m. The scan was ordered, confirmed, and marked incomplete. Again. The problem was simple. September 24th was still 4 days away. I was looking at a future appointment that had somehow already failed to happen. The system showed I'd attempted the scan twice, once on the 18th at 7:32 p.m. and again on the 20th at 9:05 p.m. Both entries included my technician ID and detailed notes about patient non-arrival. But I had no memory of either attempt. I checked the imaging archive. No scans existed. I checked the appointment confirmation log. Both time slots showed the patient checked in, prepped, and taken to the scanner. Then nothing. Just a loop of scheduled failures stretching forward and backward through time I couldn't account for. My name is Laura Brennan. I've been a CT and MRI technician at University Hospital Cleveland for 7 years. It's a large non-profit teaching hospital in suburban Cleveland, Ohio, serving a regional population of about 2 million. The radiology department operates 24/7 with 8 CT scanners, 4 MRI machines, and a constant flow of inpatients, outpatients, and emergency cases. On a normal day, I scan 30 to 40 patients per shift. During the pandemic surge in fall of 2020, that number doubled. I worked the evening shift 3 p.m. to midnight. The workflow was relentless but predictable. Patients arrived from the ER, surgical floors, and outpatient scheduling. I checked them in, verified orders, positioned them in the scanner, ran the protocol, and sent images to the radiologist. Each scan took 15 to 30 minutes depending on complexity. The system tracked everything: appointment time, patient arrival, scan start, scan completion, image upload. Every step generated a timestamp. The data was supposed to be linear, logical, sequential. In early September, I started noticing scheduling inconsistencies, small things at first. A patient listed as scanned before their appointment time. An order marked complete with no corresponding images. I assumed it was data entry errors. The electronic health record system had been recently updated and bugs were common. I reported the discrepancies to the radiology IT support team. They said they'd look into it. Then I saw patient 7341. The order came through on September 18th. Routine chest CT for a 62-year-old male with suspected pneumonia. The appointment was scheduled for 7:30 p.m. I checked the patient in at 7:18 p.m. He was thin, pale, wearing a hospital gown and a standard identification wristband. I verified his name and date of birth. He confirmed both. I walked him to scanner 3 and explained the procedure. He lay down on the table without speaking. I positioned him correctly, checked the IV line for contrast, and stepped into the control room. I initiated the scan sequence. The table moved into the gantry. The scanner powered up. Then the screen froze. The imaging software crashed. I rebooted the system and tried again. Same result. I checked the scanner hardware. No errors. I checked the patient order. Still active. I walked back into the scan room. The patient was gone. The table was empty. The IV line lay disconnected on the floor. I checked the hallway. No one. I returned to the control room and reviewed the access log. The scan room door hadn't opened since I'd closed it. I called the nurses' station to ask if the patient had returned to his floor. They had no record of him leaving radiology. I checked the waiting area. Empty. I filed an incident report and marked the appointment as incomplete due to patient departure. 2 days later, the same order appeared in my queue. Patient 7341. Routine chest CT, scheduled for 9:05 p.m. on September 20th. I stared at the screen. Same patient name, same date of birth, same medical record number. I pulled up the previous appointment. My incident report was still there. Patient left scan room. No images obtained. At 9 p.m., the patient checked in. Same man. Same thin frame, same pale skin, same hospital gown. I asked if he remembered being here 2 days earlier. He looked at me without expression. "I don't think so," he said. I walked him to scanner 3. I positioned him on the table. I initiated the scan. The screen froze. The software crashed. I rebooted and tried again. Same result. I walked back into the scan room. The table was empty. The IV line on the floor. I stood there trying to understand what I was seeing. I checked the door log. No entry, no exit. I checked the hallway. No one. I called the charge nurse. She said the patient had been discharged that morning. I pulled up his record. Discharge summary dated September 20th, 8:45 a.m. But I just checked him in at 9 p.m. I filed another incident report. I marked the appointment incomplete. I noted the discrepancy between the discharge time and the appointment time. I submitted it to my supervisor and the IT department. No one responded. The next morning, I came in early and searched the system for patient 7341. The medical record number returned no results. I searched by name. Nothing. I searched by date of birth. Nothing. I pulled up my submitted incident reports. Both were gone. I checked the imaging archive. No record of the attempted scans. I checked the appointment log. No record of the patient checking in. I went to my supervisor's office. I explained what I'd experienced. She listened and then pulled up the scheduling system on her computer. "There's no patient by that medical record number," she said. "I know, but there was. I scanned him twice, or tried to." "Do you have documentation?" "I filed incident reports. They're gone." She looked at me carefully. "Laura, we've all been under a lot of stress. The volume is overwhelming. It's possible you're confusing cases." "I'm not confused. I checked him in. Twice. He disappeared from the scanner. Twice." She closed her laptop. "I need you to take a mental health day. You're scheduled off tomorrow. Take the weekend. Come back Monday." I took the weekend. I didn't feel better. I felt like I was losing coherence. On Monday, I returned to work and found patient 7341 back in my queue, scheduled for September 24th at 8:14 p.m. The appointment was 4 days away, but the system already showed 2 prior incomplete attempts, on the 18th and the 20th. The exact dates I'd tried to scan him. The incident reports I'd filed were now visible in the system. My notes, my technician ID, everything I'd documented was back. I printed the schedule and took it to my supervisor. This patient is scheduled for Thursday, but the system shows I've already tried to scan him twice. Chomo, dates that already happened. How is that possible? She looked at the printout for a long time. I don't know, she said finally. I'll forward this to IT. Thursday arrived. I came to work at 3 p.m. and checked the schedule. Patient 7341 was still listed for 8:14 p.m. I waited. At 8:07 p.m. the patient checked in. Same man, same appearance, same quiet demeanor. I walked him to scanner 3 without speaking. I positioned him on the table. I returned to the control room. I didn't initiate the scan. I just watched him through the window. He lay completely still, eyes open, staring at the ceiling. 5 minutes passed. 10. He didn't move, didn't blink. I activated the intercom. Are you all right? No response. Can you hear me? Nothing. I walked into the scan room. He was gone. Table empty, IV line on the floor. I checked the door log immediately. No entry, no exit. I ran into the hallway. No one. I checked the time. 8:19 p.m. I returned to the control room and pulled up the appointment record. Status, incomplete. Reason, patient non-arrival. But he had arrived. I'd checked him in. I'd walked him to the scanner. I pulled up the check-in log. No record of his arrival. I checked the security camera footage. I navigated to scanner 3, 8:07 p.m. The hallway was empty. I fast-forwarded, 8:10 p.m. Empty, 8:15 p.m. I saw myself walk into the scan room, alone. I saw myself look around, then leave. I watched the footage 3 times. I was moving through the scan room as if someone were there, opening the door, gesturing toward the table, positioning invisible arms and legs, adjusting an IV line that didn't exist on camera. Then standing in the hallway, looking both ways, searching for someone who was never there. I filed another incident report. I noted the discrepancy between my experience and the security footage. I requested a meeting with the radiology director. The meeting was scheduled for the following Tuesday. Over the weekend, I reviewed every scan I'd completed in September. I found 8 more cases with similar patterns. Patients who checked in but never appeared on camera. Scans that failed for no technical reason. Appointment timestamps that preceded or followed the documented attempt dates. All marked incomplete. All involving patients whose medical record numbers eventually disappeared from the system. On Tuesday, I met with the radiology director. I brought printed logs, screenshots, and my handwritten notes. I explained the pattern. He listened without interrupting. When I finished, he opened a file on his desk. "We've been tracking these incidents," he said. "You're not the only technician reporting them. Then you know something is wrong with the system. We know the system is under extreme load. We're processing triple our normal volume. The infrastructure wasn't designed for this. That doesn't explain patients disappearing from the scanner or timestamps that don't make sense." He closed the file. "The IT department is conducting an audit. In the meantime, if you encounter a case that doesn't resolve normally, mark it incomplete and move to the next patient." That's it. That's the protocol. I kept working. I marked incomplete scans. I moved to the next patient. I stopped filing incident reports, but I kept my own log. By mid-October, I documented 43 cases. All followed the same pattern: patient arrival, scan initiation, system failure, patient disappearance, no camera evidence, timestamps that contradicted physical reality. On October 22nd, I found a memo in my mailbox. It was dated October 9th, 2 weeks earlier. The memo outlined a new protocol for handling persistent scheduling anomalies. If a patient appeared in the queue more than twice without successful scan completion, the case was to be escalated to the radiology director. The memo included a list of 12 medical record numbers flagged for review. Patient 7341 was at the top. I went to the director's office immediately. He wasn't there. I left a message. He didn't respond. I checked the scheduling system. Patient 7341 was in my queue again. Scheduled for October 24th at 7:41 p.m., 2 days away. The system showed 4 prior incomplete attempts. I'd only documented 3. On October 24th, I arrived at work early. I pulled up patient 7341's complete file. The imaging order history went back 6 months. 14 scheduled appointments, 14 incomplete scans, 7 different technicians, all documented the same experience: patient arrival, scan failure, patient disappearance. My name appeared 4 times. At 7:35 p.m., I stood in the waiting area and watched the check-in desk. At 7:40 p.m., the patient arrived. Same man, same hospital gown. He checked in with the front desk. The receptionist handed him a clipboard. He filled out forms. He returned them. He sat down. I walked over. "Do you remember me?" I asked. He looked up. "I don't think so. I've tried to scan you before." "I'm sorry, I don't remember." "How many times have you been here?" "This is my first appointment." I walked him to scanner 3. I positioned him on the table. I returned to the control room. I initiated the scan. The screen froze. The software crashed. I didn't reboot. I walked into the scan room. The table was empty. I checked my watch. 7:48 p.m. I pulled up the appointment record. Status: incomplete. Reason: patient non-arrival. I checked the timestamp. The system recorded the scan attempt at 7:51 p.m. 3 minutes in the future, I sat down at the control station and pulled up the scheduling queue. Patient 7341 was listed, again. Scheduled for October 27th at 6:33 p.m. The note field read, "Rescheduled per technician request." I hadn't requested anything. I logged out and went home. I didn't return to work on Monday. I called in sick. I spent the day searching online for similar experiences: system glitches, scheduling loops, temporal anomalies. I found nothing credible. On Tuesday, I received a call from my supervisor. She asked if I was coming back. I said I needed more time. She said the director wanted to meet with me before I returned. I agreed. The meeting was scheduled for Thursday. I arrived at the hospital at 2 p.m. The director's office was empty. I waited. At 2:30 p.m., the receptionist told me the meeting had been moved to the following week. I checked my phone. The appointment confirmation email showed today's date. I showed the receptionist. She looked confused and called the director's assistant. The assistant said the meeting was always scheduled for next Thursday. I left the building and checked my email again. The confirmation now showed next Thursday's date. I scrolled through my sent messages. I'd never requested the original appointment. The email thread didn't exist. I haven't been back to work. I still receive the schedule every week. Patient 7341 appears in the queue regularly. Different times, different days. Always listed under my technician ID. The system still shows me attempting the scan, marking it incomplete, requesting a reschedule. But I'm not there. I'm home, watching the appointments populate in real time, watching my name attached to scans I'm not performing. Last week I received a paycheck, full hours, evening shift. I haven't worked since October. The pay stub shows detailed entries: patient scans completed, break times documented, shift notes filed. I called HR. They confirmed I've been working my regular schedule. They have my badge swipes, my system logins, my completed documentation. I don't know who's scanning those patients. I don't know whose version of events is real, but I understand now. The queue was never about completing scans. It was about keeping us moving, one incomplete case to the next. one impossible timestamp to another. The system doesn't break, it just recycles. And once you're part of the pattern, you never really leave. Story 3. End-of-life revisions. I found my own intake form in the filing cabinet on a Tuesday afternoon in late July. It was misfiled under G instead of B, a simple alphabetical error. But the content was impossible. The form documented my admission to Desert Wells Hospice as a patient, not staff. It included a detailed medical history I'd never provided, advanced directives I'd never signed, and a prognosis timeline that ended 3 weeks from the date on the header. The date on the header was August 2nd, 2026. I was holding a document that described my future death. Filed in a cabinet I organized myself, written in handwriting I was starting to recognize as my own. My name is Natalie Voss. I've been an intake coordinator at Desert Wells Hospice in Flagstaff, Arizona for 2 years. The facility is a small nonprofit organization serving the rural communities of northern Arizona about 30 minutes outside the city limits. We're surrounded by high desert, pinon pine, red rock formations, and long stretches of open land under massive skies. The hospice building itself is single-story, designed to feel residential rather than clinical. 12 private patient rooms, a shared common area, a small administrative wing. We serve maybe 20 to 30 patients at a time, mostly elderly, mostly end-stage cancer or advanced neurological disease. My job is straightforward. I conduct intake interviews for new patients. I collect medical histories, document care preferences, verify insurance, and ensure advanced directives are properly completed. I coordinate with physicians, social workers, and family members to create comprehensive care plans. It's detail-oriented work, administrative. I like the precision of it, the clarity of documentation, the sense that I'm helping people articulate their wishes during an impossible time. I started at Desert Wells in August of 2024. The transition from my previous job in hospital administration was easy. The pace was slower, the environment quieter. I worked Monday through Friday, 8 a.m. to 4 p.m., with rotating on-call weekends for urgent admissions. The staff was small and stable. The patients were grateful. The work felt meaningful without being overwhelming. The intake process followed a standardized template. I met with the patient and family, usually in their home. I explained hospice philosophy, eligibility criteria, and the services we provided. I collected medical records and verified the terminal diagnosis. I walked through advance directives. Do not resuscitate orders, healthcare proxies, preferences for pain management, and end-of-life care. I documented everything in our electronic system and created a physical file for the medical records room. The files were organized alphabetically and stored in locked cabinets. In early July of this year, I was assigned to cover on-call intake for the long weekend. It was a quiet holiday. Only one admission, a 78-year-old woman with end-stage COPD. I completed the intake on Saturday morning. On Tuesday, when I returned to the office, I filed the paperwork in the medical records room. That's when I found the misfiled folder under G. The label read Voss Natalie R. I assumed it was a duplicate or a filing error involving someone with a similar name. I opened the folder. Inside was a complete intake packet. The forms were familiar. I'd designed most of them myself, but the patient name at the top of every page was mine. Natalie Rebecca Voss, date of birth, May 14, 1989. Social Security number, my number. Address, my address. I sat down at the desk and read through the file. The medical history section described a diagnosis I didn't have. Metastatic pancreatic cancer, stage 4, diagnosed in June of 2026. The prognostic timeline estimated 3 to 6 weeks from the date of admission. The admission date was listed as August 2nd. 3 weeks from the day I was reading the file. The advance directive forms were signed. My signature, dated August 2nd. The healthcare proxy listed my younger sister Emily, who lives in Phoenix. The do not resuscitate order was signed and witnessed. Preferences for pain management were clearly documented. Comfort care only, no life-prolonging interventions. Preference for home-based care if possible. The intake interview notes were written in first person, as if I'd interviewed myself. They described my emotional state as calm, accepting, focused on maintaining dignity and independence. They noted that I had no children, no spouse, and limited family support. They documented my request for minimal visitors and my preference for quiet end-of-life care. The notes were detailed and professionally written. They sounded exactly like notes I would write about a patient. I checked the date on the header. August 2nd, 2026. Today was July 15th. I was holding documentation of an event that hadn't happened yet. I checked the signature on the advance directive form. It was identical to my signature. I checked the medical history. The details were accurate. Prior surgeries, medication allergies, family history, except for the cancer diagnosis. I had no symptoms, no diagnosis. I'd had a routine physical in April. Everything was normal. I closed the file and checked the cabinet. It was filed under G between Garrison and Green. I looked for my employee file in the administrative office. It was exactly where it should be, under V in the personnel cabinet. I compared the two files, different paper, different forms. The personnel file documented my employment. The medical file documented my death. I didn't tell anyone. I took the file back to my desk and locked it in my drawer. I spent the rest of the day trying to rationalize it. A clerical error, a training template I'd created and forgotten about, a misfiled document from another facility. But none of those explanations fit. The details were too specific, the handwriting too familiar. That night I searched my home for any medical records I might have forgotten. Nothing. I checked my email for correspondence with doctors, nothing unusual. I called my sister and asked if anyone had contacted her about being my healthcare proxy. She said no. I didn't explain why I was asking. The next day I returned to the office and pulled the file from my drawer. I read through it again, looking for inconsistencies. I found none. The documentation was flawless. I checked the electronic record system to see if there was a corresponding digital file. Nothing under my name. I searched for the admission date, August 2nd. No scheduled intakes. I checked the on-call calendar. I was assigned that weekend. I started reviewing other patient files. I pulled 20 folders at random from the medical records room and went through them carefully. Most were straightforward, standard documentation. But 3 files included intake notes I didn't remember writing. The dates were within the past 6 months. The handwriting was mine. The interview details were specific and thorough, but I had no memory of conducting those intakes. I checked the electronic system. All 3 patients were listed as admitted and currently receiving care. I checked the staffing schedule. I'd been working the days those intakes were documented. I walked to the patient rooms. All 3 patients were there. I asked the attending nurse if she remembered when they'd been admitted. She checked the chart and confirmed the dates. I asked if she remembered who conducted the intake. She said she assumed it was me. I went back to my office and pulled my work calendar. I documented meetings, site visits, and administrative tasks for every day in the past 6 months. The 3 intake dates were marked as routine office days. No appointments scheduled. No notes about patient interviews. But the files existed. The patients existed. The notes were in my handwriting. I started keeping a separate log. Every morning I reviewed the medical records room and noted which files I'd created. Every evening I checked again. New files appeared regularly. Some I remembered completing, others I didn't. I began photographing the files I didn't recognize and comparing them to my known documentation. The style was identical, the level of detail consistent, the handwriting indistinguishable. In late July, I found 3 more files I didn't recognize, all documented intakes conducted on weekends I'd been off call. All signed with my name. I checked the patient census. All 3 patients were listed as active. I asked the weekend coordinator if she'd covered those intakes. She said no. She confirmed I'd been listed as the intake coordinator for all 3 cases. I pulled the weekend on-call logs. My name appeared on the schedule for days I hadn't worked. I checked my phone records. No calls from the hospice number on those dates. I checked my mileage logs. No trips to patient homes. But the documentation existed. The patients existed. My signature existed. On July 29th, I received a scheduling notification for an on-call intake on August 2nd. The patient name was listed as Voss, Natalie R. The appointment time was 9 a.m. The location was my home address. I stared at the notification for a long time. I checked the electronic system. The appointment was officially scheduled. The patient, demographics matched my information exactly. The diagnosis field read, metastatic pancreatic cancer, stage 4. The referring physician was listed as Dr. Samuel Kearney. I didn't recognize the name. I searched the provider directory. Dr. Kearney was listed as an oncologist at Flagstaff Medical Center. I called his office. The receptionist confirmed he was on staff but said he wasn't accepting new patients. I asked if he had a patient named Natalie Voss. She said she couldn't disclose that information. I called the hospice director. I explained the scheduling error. She pulled up the system on her end and said there was no appointment for August 2nd. I sent her a screenshot. She called me back 20 minutes later and said the IT department was investigating a possible data breach. She asked if I'd entered my own information into the system for any reason. I said no. That night I couldn't sleep. I kept thinking about the intake form in my drawer, the advanced directives with my signature, the medical history that described a disease I didn't have. I got out of bed and checked my body for symptoms. No pain, no weight loss, no jaundice, no fatigue beyond normal stress. I felt fine. On August 1st, I went to the emergency room. I told the attending physician I needed imaging. I explained I was concerned about pancreatic cancer. She asked about symptoms. I said I had none. She asked about family history. I said there was none. She ran standard blood work. Everything came back normal. She said there was no clinical indication for advanced imaging. I insisted. She reluctantly ordered a CT scan. The results were normal. No masses, no abnormalities. Pancreas unremarkable. I went home and pulled the intake file from my desk. The diagnosis was still there. Metastatic pancreatic cancer. Stage 4. I checked the date. August 2nd was tomorrow. I didn't go to work the next day. I called in sick. I stayed home and waited. At 9 a.m., no one knocked on my door. No hospice staff arrived. No intake interview occurred. I checked my phone. No missed calls. I checked my email. No messages. At 10 a.m., I drove to the hospice office. The building was open. The staff was working normally. I checked the schedule. No appointment listed for Voss, Natalie R. I went to the medical records room and opened the filing cabinet. The folder was still there under G. I pulled it out and read through the intake notes again. The date at the top of the form read August 2nd, 2026. Today. The interview notes described a conversation that had taken place this morning at 9 a.m. The notes included direct quotes. My words describing my acceptance of hospice care. My wishes for end-of-life treatment. My request for minimal intervention. I checked the signature on the advanced directive, dated August 2nd. Today. I held my hand next to the signature. Identical. I took the file to the director's office. I laid it on her desk and explained everything. She read through the forms carefully. When she finished, she looked at me for a long time. "This is your handwriting," she said. "I know. And this is your signature. I know. But you didn't complete this intake." "No." She closed the folder. "I'm going to recommend you take a leave of absence. I think you're experiencing significant stress." "I'm not stressed. I'm telling you there's something wrong with the documentation system. Natalie, you've been creating intake files for patients who don't exist, or for admissions that haven't happened. The IT department has been tracking it for weeks." "What are you talking about?" She opened a folder on her computer and turned the screen toward me. It showed a log of flagged documentation. My name appeared 37 times. Intake forms completed for patients with no corresponding admission orders. Advance directives signed by people who hadn't. Enrolled in hospice. Medical histories documented without physician referrals. The dates spanned the past 6 months. "We thought it was a system error," she said. "But IT confirmed all the entries originated from your login." I stared at the screen. "I didn't create those files. Your login credentials were used. Your handwriting is on the physical forms. Your signature is on the advance directives. Then someone else is using my credentials." She closed the laptop. "I'm requiring you to take medical leave, effective immediately. We'll revisit your employment status after you've been evaluated." I left the building. I drove home. I sat in my living room and tried to reconstruct the past 6 months. I reviewed my calendar, my logs, my photographs. I couldn't find gaps. I couldn't find lost time. But somewhere in hours I thought I'd lived normally. I'd been documenting deaths that hadn't happened yet, including my own. Last week I received a letter from Desert Wells Hospice. It was a discharge summary. It documented the completion of my care. It noted that I died peacefully at home on August 19th, surrounded by family with excellent pain management and emotional support. The attending nurse was listed as Maria Gonzalez. I know Maria. She's worked at Desert Wells for 5 years. The summary was signed by the hospice medical director. It was dated August 21st. Today is August 23rd. I'm still alive. I feel fine. But the file exists. The discharge summary exists. And somewhere in a cabinet I organized myself, there's a folder that says I've already finished. I just haven't realized it yet. I think I understand now. Some documentation isn't reactive, it's preparatory. The system wasn't recording what happened, it was preparing what will. And once your file is complete, approved, and signed, the timeline adjusts. You just keep working until the paperwork catches up. I'm still conducting intakes. I'm still writing notes, but I don't know whose version I'm living anymore. The one filing the reports or the one being filed.